evening, wherever you are. On behalf of USSP and the organizing committee of the 2021 International Population Conference, it's my great pleasure to welcome you all to the inaugural keynote address. I am K.S. James, Director, International Institute for Population Sciences from India. What you have just seen is a video prepared by IUSSP on why demographers unite on understanding a range of contemporary population challenges and how demographers can unite and contribute. I'm sure you have all enjoyed the video. We are now moving to the next program of today's is the inaugural keynote address. I'm indeed honored to introduce the keynote speaker of today, Dr. Soumya Swaminathan. As all of you know, Dr. Soumya is the chief scientist of the WHO in Geneva. He is among perhaps the most eminent and respected scientists. She has an illustrious career and demonstrated how to take science to the benefit of the large sections of the population. She has indeed dedicated her entire life for the research and generating evidences to improve the life of the millions of people. Dr. Swaminathan received an MBBS from the Armed Forces Medical College in India and secured an MD in pediatrics from the prestigious All India Institute of Medical Sciences in New Delhi. And she completed a postdoctoral medical fellowship in neonatology and pediatrics from the USA. Growing up in a family of renowned agricultural scientists, her father, and a creative and socially responsible mother, Dr. Swaminathan practically had set her career path as a scientist in her even childhood. That is clear from her own words, which I quote here. I realized the power of research evidence being able to influence public policy and practice. This spurred me to address questions that were relevant to India's TB and HIV programs in the 1990s and 2000s. She was passionate in improving the lives of the people through her research. She was instrumental in revamping the India's tuberculosis program using digital technology. Dr. Swaminathan started a multidisciplinary group of clinical laboratory and behavioral scientists studying various aspects of TB, HIV, and was part of the No TB City project in the country. During her illustrious career, spanning over a few decades now, she was Deputy Director General of Programs of the UN body and also served as a Secretary to the Indian government for health research and also Director General of Indian Council of Medical Research, Government of India. India has immensely benefited from her thought leadership. Prior to this, Dr. Swaminathan was a coordinator of the UNICEF, UNDP, World Bank, WHO special program for the research and training in tropical disease in Geneva. As all of you are aware, currently as a chief scientist, Dr. Swaminathan is spearheading the WHO's COVID responses. We are indeed fortunate to have Dr. Swaminathan delivering the keynote address for the International Population Conference of IUSSP 2021. Ladies and gentlemen, let us all welcome Dr. Swaminathan for the keynote address. And I would request, please start her video.
Excellencies, dignitaries, ladies and gentlemen, friends, it gives me great pleasure to be addressing you today, and thank you very much for this opportunity to let me share a few thoughts on my learnings as chief scientist at the World Health Organization. What lessons have we learned for science and for public health from the pandemic? As we speak, the world has seen more than 256 million cases and over 5.1 million deaths. Of course, these are probably underestimates, because we know that in many countries the diagnostics and the testing is not available, and the ratio between the proven cases and notified cases to the real true number of cases ranges from 1 in 2 in some highly developed countries with a lot of diagnostics available to 1 in 100 or 1 in 400 in some countries. Similarly, deaths, we know that the civil registration and vital statistics systems are still weak. In many countries, deaths are not always reported, and even if they are reported, there is no cause of death, medical cause of death attributed. So again, these very basic health statistics like mortality and cause of death, often we do not get. In fact, it's 7 out of 10 deaths around the world, we do not have a medically certified cause of death. And so this really limits the opportunities for policymakers to understand the true burden of disease, whether it's COVID or other diseases, and to take action based on data. And so this is, I think, one of the learnings is strengthening basic systems, strengthening data systems, strengthening primary health care, strengthening surveillance, and the ability also to analyze and make sense of the data and have it feed into policy guidance. We know that today the Delta variant is a predominant variant, which accounts for more than 99% of sequenced cases in the last 60 days. As you know, that genomic sequencing has taken on a big role and has shown how important it has been for us to be able to first get to know about this new virus. On January 10th, of 2020, the Chinese scientists first put in the public domain in a global database called GISAID the first few sequences of this novel coronavirus. So, and that's what started all of the development of diagnostics and vaccines and so on. So from that to today, when we have over 5 million whole genome sequences in this database called GISAID, we are able to track the evolution of the virus, the different variants that arose from time to time. Of course, there have been hundreds of mutations that have been recognized, but when we characterize something as a variant of interest or a variant of concern, it means that it has certain properties, certain mutations that we know today do cause changes in the properties of the virus. They either increase the transmissibility by making it even more possible to adhere to the receptors on the cells, the ACE2 receptors, or some mutations which are able to overcome the neutralizing antibodies. So you need higher levels of neutralizing antibodies, which means that the virus can become resistant to vaccine or natural induced immunity. Now, luckily for us, the 4 variants of concern, alpha, beta, gamma, and delta, and of course, as I said, delta is predominant globally today. While transmissibility of the delta variant is very high, and this is why you see these explosive outbreaks and clusters, very difficult to contain once it takes off in the community, but also that it is partially resistant to the neutralizing antibodies, and so you need higher levels of antibodies in the blood to be able to overcome the virus and to get rid of it. And this is why we see that while the vaccines that we have today and are using are still very highly protective against severe disease and hospitalization and death, they are not entirely protective against infection, maybe in the range of 40, 50, 60%. And so you do see vaccinated people developing infection and being able to spread it to others. The viral loads in vaccinated people are the same as in unvaccinated people. And the only thing is that people don't get sick because their immune systems are primed by the vaccine. So they're able to mount a strong and rapid immune response, limiting the damage that the virus can do. But the clear message is, firstly, this virus is going to continue to mutate, evolve, try to overcome the defenses. And so we have to be very carefully monitoring and watching the emergence of new variants. And every country, I think, has really tried to strengthen their own genomic surveillance systems, which is going to be useful not only for COVID, but also for the future for other pathogens that cause public health threats. So it's really important to invest in that, but also to make sure that this kind of data is shared rapidly, globally, and this is going to help us again in the future. And secondly, what we've learned is that the more we give the virus chances to transmit, to multiply, to infect people, the more the chances of mutations and new variants emerging. And the third lesson is that even when people are fully vaccinated, they still need to follow other precautions like wearing a mask, avoiding crowded places, making sure that there is good ventilation whenever there is a gathering of more than a few people, and testing when symptomatic, isolating, etc., because we know that these vaccines are not going to prevent the infections 100%. So these are some of the lessons we've learned. Of course, we still have a lot of questions about the duration of protection of the different vaccines, the kind of immune response that it stimulates. We're learning more and more that T-cell immunity is important, cell-mediated immunity is as important, if not more important, than neutralizing antibodies. We need to understand also the efficacy of different vaccines in different age groups and against different strains of the virus, and this is going to determine the policy on boosters, for example, because boosters will be needed if we find evidence of waning immunity, either in certain subgroups, the elderly, the immunocompromised, but we need still data. There are very few countries that are systematically collecting and sharing this type of data from their vaccinated population. So it will be really good to see more data coming from a larger number of countries. We know that almost 8 billion doses of vaccines have been administered around the world. This itself is a spectacular scientific accomplishment. The fact that in under 2 years of the detection of a new pathogen, we not only developed a number of vaccines but are able to vaccinate such large parts of the world. 8 billion doses administered is no mean feat. And so it brings out clearly that today we have the tools, we have the science, the knowledge, the technologies to develop countermeasures, and these can be done very rapidly. They were done in about 300 days. We had the first vaccine. Potentially the next time we can do it in even less, maybe in 100 days or 200 days. But what we need is also the ability to be able to manufacture these vaccines around the world, to distribute them, to share them equitably, and this is why we are now working on these technology transfer hubs, which will essentially mean that we're setting up these training hubs in low and middle income countries to train teams on mRNA technology, the new viral vectored technologies and other technologies, so that we have a distributed network of manufacturing sites which can be producing other types of vaccines and health products, monoclonal antibodies, for example. But during a pandemic, they can be repurposed, and then they can quickly switch over to making vaccines and monoclonals for the new pathogen. So this is important because of what we've seen, in the inequities in the distribution of vaccines, and the fact that while many countries, especially the high income and upper middle income countries, have already vaccinated 50, 60, 70% of their population, on average in Africa, for example, the population coverage is still under 5 to 6% in the majority of countries, except for a couple of them. And so we need to address that very, very urgently. And the Director General, Dr. Tedros, has spoken a lot about vaccine equity, about vaccine nationalism, and about the fact that when we are facing a pandemic, we need to consider ourselves as one global community. We cannot solve the problem if we do it country by country or even region by region. And it's not only vaccines. We know that the inequities in access to diagnostics, for example, is 100 times between high income and low income countries. And WHO has a benchmark today of doing at least 100 per 100,000 tests per day, which means that and this could be PCR tests or rapid diagnostic tests. And while many countries initially struggled, to do testing, it's much better now, but still it's not up to the levels where it needs to be. And as we said earlier, if we don't do diagnostic testing, then we are basically flying blind. We really don't know where the virus is and how much it is circulating in the communities. Similarly, on therapeutics, we initially focused on repurposing existing drugs. We also understood the pathogenesis of the disease because of all of the work that was done initially in China and then later on in other countries by the doctors and scientists who really documented their experiences. I think it's been an incredible learning curve, and almost every day you have a number of new publications coming out where you understand better the epidemiology, the transmission, the clinical features, the management, etc. And so dexamethasone was the first drug that was shown to be effective in reducing mortality in severe and critical patients. The Solidarity trial actually was set up by WHO to be able to do rapid and robust assessment of drugs. Started in April of 2020, involves today more than 50 countries, more than 600 hospitals around the world. I think is a great example of how the world, ministries of health, hospitals, doctors came together to say this is important, we need to do this jointly. And the publication has more than 1,000 authors because of this type of global collaboration. So the first phase of the Solidarity trial tested 4 repurposed drugs, including remdesivir. The second phase, which is ongoing now, is testing 3 more repurposed drugs, artesunate, infliximab, and imatinib. All of them are being tested for their anti-inflammatory effects in people who are already hospitalized with COVID-19. So the good news is, of course, now we have 2 new antivirals that have been developed by Merck and Pfizer. They just put out some data. We haven't seen the complete data set yet, but they look promising. They need to be given early in the course of infection to be effective. So this is why, again, testing is very important. So to be most effective, first 3 to 5 days of infection starting, that's when the viral phase is going on, viremic phase. You give these drugs to people with underlying high-risk conditions, comorbidities, elderly, etc. It prevents them from deteriorating and needing hospitalization. So the Merck drug molnupiravir was shown to be 50% effective, and the Pfizer drug was shown to be 89% effective in reducing the need for hospitalization and death. However, these are just the first results from the first clinical trials, and we need, as we scale up these treatments, we need to collect more real-time data, real-world data. We need to do good pharmacovigilance and monitor and then learn how to use these tools, and also monitor for drug resistance, because we know that from past experience that antivirals, you can develop drug resistance. The WHO developed what we call the living guidelines in order to address the issue of rapidly changing evidence and new data coming in. And so we have these living guidelines for drugs, for therapeutics, which are updated by doing systematic reviews, and our guideline development groups make a recommendation on each of these products, monoclonal antibodies, on antithrombotics, on these other repurposed drugs we talked about, the IL-6 inhibitors, and currently they're looking at these 2 new oral antivirals. And this has been a very good approach where the science division in WHO worked with the clinical lead in the emergencies program in order to put this onto this living format. They are digital, computable guidelines that are available, and the guidelines are always published along with the background information and evidence. One of the things, of course, that happened in this pandemic is that a lot of unproven therapies and remedies were being tested, and it is fine to test them if it's done within a research study, within a trial, but many of these were just advocated for general use, for broad use, without any evidence. And even when the trials came in showing that those drugs are not effective, they were still being promoted by some groups of people. So I think it's important also for medical people and the lay public to understand what an evidence base is. How do you assess the evidence between good and bad studies. The quality of the studies is as important, and so this is why one of the things that we've focused on really is how do you get the best data and sift through all of the information, the huge amount of information. We call it infodemic. Everybody started publishing, both the lay press as well as in the scientific press. One has to sift through all that. You need experts to look through it and to figure out which ones really need to be taken seriously and taken forward into guidelines and which ones don't. So I think building scientific literacy amongst the public is also an important thing for us to think about in the future. Health literacy, scientific literacy are very important, should be inculcated right from the school days and college days so that people start thinking rationally. Then in terms of primary healthcare delivery, there have been a lot of innovations, a lot of use of digital technologies, telemedicine, contact tracing apps, other apps. We are focusing in the science division on developing standards and guidelines and norms for the use of artificial intelligence-based technologies, for the use of, for example, the digital certification for COVID-19. This is one of our first products on technical standards which can be interoperable, that is now available for member states to use. And similarly, we've provided guidance which also looks at the ethics of some of the new technologies, like using contact tracing apps, human challenge studies for vaccines, artificial intelligence based diagnostics. So in all of this we have, and of course we continue to work on recommendations and guidelines, and as countries move more and more into digitally enabled health services, what we would like to see is national digital health strategies. We would like to see integration of different elements. We'd like to see a good governance structure and mechanism, a focus not only on technology but on workforce, on training existing staff and new staff on the use of these digital tools. But most important is the focus on health outcomes, because digital is an enabler and it should be really helping us and helping our healthcare workers to do their work better, to do their job better, and to be able to see those results in terms of improved health. And so that's important also to undertake a monitoring and evaluation and research studies, both quantitative and qualitative methods, to assess the impact of changing the ways of doing care delivery, and also very importantly to see if any groups are being further excluded. Are we excluding the elderly, the disabled, the vulnerable, the people without access to internet services? If so, then we are actually increasing inequities. And so when we think about digital health, I always think about who are the people who will not be able to access this, and what do we do to make that to cover that that gap. So I think finally I would like to say that the important elements, and the difference between success and failure really when you're talking about these global kind of threats is really the issue of leadership, of coming together, of solidarity, of building trust and accountability between the government and the public, and also between different countries who are willing to share, willing to work together. And it's happened partially, but I think that there are still a lot of gaps. And so I think these terms, that we often use, like equity, solidarity, inclusivity, transparency, accountability, sustainability, all of these actually have a good amount of meaning for minimizing the risks to our health and maximizing the opportunities and leveraging the new opportunities that have come up for all countries, communities and individuals. And it's important really to think about what kind of governance will be needed at the global level, but also at the national level. What kind of financing is going to be needed for us to really invest in universal health coverage. Universal health coverage will take care not only of health emergencies, but of all of the other major health issues, including non-communicable diseases. and we need the tools and the systems to enable this to function. So governance, financing, systems and tools are all going to be very important, but nothing will be successful without engaged and empowered communities. Ultimately, that's where the action is, and if communities are not engaged and well informed and participating in their own, taking responsibilities for their own health and in the health of their families and communities, ultimately that's going to be the success story. So once again, I would like very much to thank you for this opportunity. Wish you well, and always available at WHO to provide any support, advice, and of course engage in dialogue. Thank you so much.
Thank you. Thank you, Dr. Soumya. Dr. Soumya has touched upon various aspects of COVID management by WHO, as well as by the different countries in these troubled times all of us are in currently. She has started her talk by emphasizing the data system strengthening for the COVID-19, which is the most important aspects for not only for the WHO, but for different countries of the world. She also looked at what is the implications of different variants of the COVID, which will have on the population health at large, and also later dealt on the need for collaboration, both the national governments as well as international bodies, and also the scientific community as a whole. As a scholars, it is important to bring together. And finally, she has concluded by emphasizing on the digital aspects, which can create inequities, which also can create lack of inclusiveness, and how do we empower the communities and make sure that our COVID responses are achieved to the maximum benefits to the millions and millions of the people around the world. Thank you so for that wonderful lecture. But unfortunately, Dr. Soumya is unable to join us today because of some other engagement. But in case you have any questions to ask her, please feel free to type it in the question and answer section. We will communicate her your questions, your suggestions, or any other things you would like to convey to Dr. Soumya Swaminathan. Thank you all for participating. But before we end this section, we have also one more other video. As all of you know, this IUSSP conference is being co-hosted by Indian Association for the Study of Population, IASP, in India. The Indian Association for the Study of Population and the National Organizing Committee have put together a tribute to one of its outstanding members and an eminent demographer, Dr. Krishnamurthy Srinivasan. And a video has been prepared on that. Ladies and gentlemen, please enjoy this video on Dr. Srinivasan. Over to the organizers.
The Indian Association for the Study of Population is indeed happy and deem as an honor to display this video on Dr. Krishnamurthy Srinivasan, whose contribution to Indian demography is phenomenal. Professor K. Srinivasan has made valuable contributions in the area of population studies and programs since 1959. He is not only an internationally acclaimed academician and in the field of demography, a teacher and a researcher, but also has served the country through various national and international committees and associations. He was a member of the National Statistical Commission set up by the Government of India in January 2000, which submitted its report in August 2001 to the Prime Minister recommending revamping of the statistical system in the country. He served as a member of the Working Group on Population Policy set up by the Planning Commission during 1978-1979. He was awarded the National Fellow in 2013-2015 by the Indian Council for Social Science Research (ICSSR) to review the history of family planning programs in India. He has also made his contributions to other developing countries in the field of population studies and research under the auspices of United Nations and other international organizations. He was employed with the Population Division of the United Nations at their ESCAP office in Bangkok, and his work has been well appreciated by other countries. As a senior professor and director of the International Institute of Population Sciences, IIPS, in Mumbai from 1978 to 1992, he expanded the academic and geographic scope of the institute by making it a deemed university and training a large number of students from other Asian countries with financial assistance from the UNFPA. He was also instrumental in starting the National Family Health Survey NFHS-1 in the country during 1991 and 1992. NFHS has become a rich source of reliable data on population and health in India. He has numerous books and national and international peer-reviewed academic publications to his credit. His seminal work on birth intervals done in the 1960s continues to be cited widely. His most recent book, published in 2017, Population Concerns in India, Shifting Trends, Policies and Programs, has been released in 3 languages. Despite advancing age, Dr. Srinivasan continues to be actively involved in research, writing, and guiding other academicians, researchers, and young scholars in demography and contributing to various research institutions and professional associations in the country.
I started my professional life after completing my master's course in statistics at the Indian Statistical Institute, Calcutta, at Gandhigram in 1959. I came there as a statistician in a pilot health project which was started by ICMR and Ford Foundation, mainly to improve the health conditions of the people in Athur block. I stayed there from 59 to 69, 10 years, but during that time I was selected for a Ford Foundation fellowship to go to Harvard to do my master's in public health during 61-62. And I also finished my PhD from Kerala University, which was nearby, in 1968. So Gandhigram gave me a professional reputation, and since I did some fundamental work on birth intervals, particularly open birth intervals, which got me name and fame, this helped me to get a UN assignment from Bangkok. So my life was in a way peculiar. I came from Boston to Gandhigram, then Gandhigram to Bangkok. And somehow the UN assignment, though I did my best to do a number of training courses on fertility and family planning evaluation to many of the developing countries and evaluate their programs, my heart was closer to India. So after completing 5 years there, I came to Bangalore, where I was offered the post of Director of a Population Center, Bangalore, which was a World Bank project. I worked there for 3.5 years before I moved to International Institute for Population Sciences, Bombay, in 1978. And I spent most of my professional life there. One of the most joyful moments of my professional life was in 1985, when that institute was declared as a deemed university. Actually, one Mr. Jiang Shenghua, who was my student for MPS course, became later the chairman of the State Family Planning Commission in China, almost a ministerial level position there. And he was instrumental largely in spearheading the one-child policy there. The second big thing which I had in IIPS was to launch the National Family Health Survey, and one in 91, 92. And when I started it, I never knew that it will become one of the richest sources of data on population health, nutrition, and many other parameters for the country as a whole over time. After completing my term at IIPS, I moved to University of North Carolina for a 1-year visiting assignment as a professor, where I published a book, and that book has been well received by the demographic community. Then I joined the Population Foundation of India in New Delhi as its executive director in 1995, and which position I held till 2002. The Population Foundation of India was started by late J.R.D. Tata and a few colleagues. You know, J.R.D. Tata felt that a program like family planning or reproductive health cannot be only, it should not be the sole responsibility of the government agencies, but many non-governmental organizations also should help in this endeavor. So I encouraged large number of NGOs to take responsibilities in reproductive health and family planning programs in their own areas. I retired from Population Foundation of India in 2002 when I moved to Bombay. I became an emeritus professor there. I moved to Chennai 2009, which was my hometown. And I'm still continuing my work there, though not traveling that much. So it is my real pleasure that the IASP, Indian Association for Study of Population, for which I was the president during 1999 to 2003, is having this program. I still remember vividly the conference, annual conference of IASP held in Visakhapatnam in 2001, where it was attended by Mr. C. Rangarajan, Governor of Reserve Bank of India. So I am happy that the IASP is in the hands of very capable persons like Dr. Soumya and Mr. Subramaniam, who have spent a lot of time planning for the conference once in 4 years held by the International Union for Scientific Study of Population at Hyderabad. But unfortunately, that conference could not be held in person. So this virtual conference is going to be successful, and a lot of credit for it should go to Dr. Soumya and his team, and also to Dr. Shireen Jijibai, who is going to be the president of IUSSP. And I had the pleasure of working with her at IIPS in the late 70s, and I'm happy she is going to be the next president of IUSSP. Thank you very much.
Thank you. Thank you. Let me thank the Indian Association for the Study of Population for preparing this wonderful video as a tribute to one of the India's finest demographers, as world demographer, Professor K. Srinivasan. We are almost towards the end of the inaugural keynote address today. I think it's my great pleasure first to thank IUSSP for that wonderful video they have prepared on why demographers unite. I think it has been really a tribute to understand what are the major challenges in the demographic field in coming years, as well as to IASP for this wonderful video on Professor Srinivasan. It's also my great pleasure to again thank Dr. Soumya Swaminathan for sparing her time for providing keynote address on the IUSSP conference. I think we all really enjoyed her talk, and I'm sure she will continue to be associated and a well-wisher for the IUSSP in coming years as well. Friends, that ends today's program. So all of you are invited to come as a live audience to chat at the gather.town. You can really go to the poster gallery and click gather.town, where we can have a live conversation or live chat across the audiences which are participating in the IUSSP conference. So all of you know this is all virtual. Now we are not able to meet, but still IUSSP is able to make a real scenario where we are able to communicate each other through a virtual mode. Thank you all for participating once again. And that ends the inaugural keynote address session of today. Thank you and namaste.